So here we are introducing Unit 7 for pharmacology, and this unit is going to focus on respiratory antihistamine and GI drugs. So drugs for the respiratory system. We're going to talk a little bit about histamine, and we're going to talk a little bit about the gastrointestinal drugs and the pathologies for which they are appropriate. So I want to just start by doing our general introduction and anatomy and physiology review of, in this case, the respiratory system. And we're just going to mostly focus on, I should preface this by saying there's not a whole bunch of drugs that we're going to be focusing on in this unit, but we are going to talk quite a bit about regulating respiration. So in order to do that, I want to describe the normal regulation of the respiratory system, including the location of the respiratory center and the mechanisms which can modify the action of the respiratory center. So that's kind of where we're going to start. So the respiratory center is located in the brain stem to be exact, in the medulla oblongata, and mechanisms that can modify its action. So there's a bunch of things that will affect the respiratory center, one of which is higher brain centers. So the respiratory center is being located in the brainstem. It's kind of in a relay area, right? All the ascending and descending information that either enters or exits the central nervous system has to do it via the brainstem. So higher brain centers, which would mean like someplace, above the brainstem essentially, can definitely influence the respiratory center. Sensory stimuli can influence the respiratory center. So whether that be, so all kinds of sensory information coming in can do it. Any changes specifically in oxygen in the blood, carbon dioxide in the blood, and pH of the blood will definitely affect the respiratory center, and definitely most acutely. Of those three, the biggest driver of minute-to-minute changes in respiration is the increase in changes in carbon dioxide in the blood, either increased or decreased. But when carbon dioxide levels in the blood increase, that will additionally lead to a change in the pH, right? There's a direct relationship between increase in the carbon dioxide in the blood, hydrogen ion concentration, which of course hydrogen ion concentration is then inversely related to pH. So what I'm saying is if blood CO2 levels increase, that will cause an increase in hydrogen ion, and this all has to do with that whole carbonic acid, equation that you learn about in physiology. So increase in CO2 leads to an increase in hydrogen ion, or an increase in hydrogen ion in the blood will also cause an increase in CO2. When that happens, that will then lead to a decrease in pH, which we refer to as acidosis. If you recall, the range for blood pH is 7.35 to 7.45, and this is probably, of all of our regulated variables, the one that is the most important. So those two are probably the most sensitive factors that will change respiration. When blood concentration of carbon dioxide increases or hydrogen ion concentration increases, that stimulates the respiratory center to increase ventilation. So essentially what we're trying to do is we're trying to increase the expiration of that carbon dioxide. So when we breathe fast, we hyperventilate, that causes us to expire carbon dioxide, which would bring carbon dioxide levels down, which in turn would bring hydrogen ion levels down, which would then, of course, bring pH up. So of those on the list there, increased carbon dioxide and consequently acidosis are probably the most significant markers in terms of altering respiration. Decreased oxygen will do it as well. I'm going to show you a picture in a minute and make a little bit more sense out of that. Decreased oxygen levels are going to be less acute, but they definitely will play a role. One thing that's really important to understand in the context of respiratory disease is that many of our respiratory diseases that fall in the category of the obstructive pulmonary diseases, and what I'm thinking about primarily here is chronic bronchitis / emphysema, those disease processes cause carbon dioxide levels to increase in the blood. I'll talk a little bit more about that later. But when carbon dioxide levels increase in the blood slowly over a long period of time, which would happen in a chronic disease, the respiratory center appears to lose sensitivity to that carbon dioxide, which means that increased carbon dioxide no longer is stimulating ventilation. And in those circumstances, then that decreased oxygen is supremely important because that's the primary driver for ventilation. So let's look at a picture here and I'll explain this to you a little bit more. So what we're looking at here is essentially the brainstem. It's obviously not a very great picture of it, but showing us the relationship between carbon dioxide sensory input and the ultimate the response, which would then cause us to hyperventilate to get rid of that carbon dioxide. So high carbon dioxide definitely stimulates breathing. Low carbon dioxide definitely inhibits breathing, right? Oxygen, let me stand back for a second. Oxygen will also decrease levels of oxygen in the blood, will also influence respiratory rate, but it's going to be a lot less sensitive. Just to remind us, I get a little reminder about what's happening with ventilation. So the whole point of the respiratory center is to be able to oxygenate our blood and get rid of the carbon dioxide. So when we breathe in oxygen from the atmosphere, right, there's a huge partial pressure gradient for oxygen. There's a lot of oxygen in the atmosphere. There's not a lot of oxygen in the lungs, essentially. And so oxygen moves down its gradient from high concentration to low. That's what happens when we breathe, when we inspire. When we expire the carbon dioxide. Carbon dioxide is our primary metabolic waste. We're producing it all the time. Every cell that metabolizes, which is every cell, produces carbon dioxide as a waste product, as you hopefully remember from your love of the Krebs cycle and oxidative phosphorylation and electron transport. We produce a lot of carbon dioxide as a byproduct of metabolism. It moves from the cells into the blood, from the cells into the interstitial tissue fluid, then into the bloodstream, back to the lungs, where we expire it. So that's kind of the relationship there. So if somebody has a disease like, let's say, emphysema, which causes them to retain carbon dioxide because of the disease process, which we'll talk more about later, that means they're not able to get their carbon dioxide out. And that can also mean if there's a lot of destruction to the alveolar walls, they're also not able to get oxygen in. So that's kind of the relationship. With respiratory disease, we kind of would expect if there's a lot of damage to the respiratory membrane, we would expect carbon dioxide levels to go up and consequently oxygen in the blood to go down. We're thinking about the levels in the blood because that's what we have access to. That's what we can measure. All right, so let's break this down a little bit with some of our A&P and talk about some abnormal conditions that can result in decreased oxygen tension or oxygen levels in the blood. So here's our respiratory tract. It's, again, not a super great picture, but it will do the job. So we've got the airway, which is going to be comprised of the nasal cavity, the pharynx, the larynx going down, the trachea, which is our big tube that sits in front, goes down the front of the throat. It sits in front of the esophagus. It has cartilaginous rings. You can feel those rings if you run your hands down the front of your throat. The cartilaginous rings, of course, keep the airway open. Then what's going to happen, so here we are, right, trachea, you can see the cartilage. Then we're going to bifurcate down here into the primary bronchi or the main stem bronchi. We've got the right side and the left side going into the right lung, the left side going into the left lung. So we have primary bronchi, secondary bronchi, tertiary bronchi, and then we go into our small area, our small airways, which have a lot of smooth muscle, which becomes important to us later. And those are called the bronchioles. And then, of course, let me back up. We don't see them on that picture here, but then, of course, we would have the alveolar ducts and the alveoli, which we'll see in a picture in a few minutes. This is kind of what the primary breaking of the primary bronchi into the secondary, and ultimately we'd have tertiary. Those tubes get pretty small, so we're not going to be able to see them with our eyes. Other thing to note about the respiratory tract is the respiratory tract is lined with epithelial tissue, and that epithelial tissue has two things: an abundance of cilia, which you can kind of see here, and abundance of cells that produce mucus. These are the goblet cells, right? You can see those guys in there. So we produce a fair amount of mucus normally, more in the cases of pathology and the cilia. The job of the cilia is to rhythmically beat and beat towards the outside. So beat towards, like if you're going to say beat towards maybe the nose or the mouth. And in tandem with the mucus, we have the ability to trap any kind of particulate that we may inhale. So the combination of the mucus and the cilia comprise what we refer to as the mucociliary elevator, which I love that term because it's so clear. And its whole purpose is to trap particulate and then rhythmically kind of beat and throw it back towards the outside of the body so it doesn't continue to get down into the deeper portions of the respiratory tract. Some pathologies, like the one that comes to mind right now is smoking, will cause the cilia to blunt, flatten, and then you lose the ability to trap that particulate, which is very important. Anytime we're acutely ill, the cilia seems to kind of lay flat. Alcohol is another thing that causes the cilia temporarily to kind of lay flat. So these are all things that increase the ability to get particulate down deeper and allow for irritation of the lower portions of the respiratory tree. All right, so back to the bronchioles. So these guys do not have any cartilage. They do have an abundance of smooth muscle. The absence of cartilage means that they're not always held open. The abundance of smooth muscle means they are responsive to mediators, especially the autonomic nervous system. They can constrict and they can dilate. There's going to be receptors there. The beta 2 receptor is the one notable for controlling the airway down here. And that causes bronchodilation. The parasympathetic effect at the airway is to constrict. So that changes the diameter of that tube, and it changes the way the air flows through there, right? When you constrict a vessel, the air is going to flow more turbulently, and that can potentially cause some issues as we get down into the alveoli. So we've got the bronchioles, who then bifurcate or split into our little itty bitty tubes, which are called the alveolar ducts, which terminate in these grape-like structures, which are alveoli. The alveoli is where it all happens in terms of respiration, right? That's the respiratory membrane, the interface between the alveoli and the capillaries, which we'll see a picture of in a minute. So we ran through the airway. So I really want to focus on these alveoli for a minute. So again, they look like grapes, and there's so the air is inside this tube, right? And it moves into these little grape-like structures. On the outside of the alveoli, we have these dense capillary networks. So recall the setup of the lungs for a second, and the relationship between the lungs and the cardiovascular system. So all the blood that comes back to the right side of the heart comes from our circulatory system, right, from systemic circulation. So the blood that's picking up carbon dioxide, which is our primary metabolic waste, as we discussed previously, carbon dioxide gets loaded into the blood at the tissue capillary interface systemically, and that carbon dioxide travels back to the right side of the heart through the venous system and through the superior inferior vena cava, and then into the right side of the heart. Once it gets into the right side of the heart, it goes atria to ventricle, as we know, and then when the right ventricle contracts, it sends that carbon dioxide-rich blood, oxygen-poor, carbon dioxide-rich blood to the lungs, right? And it leaves the right side of the heart via the pulmonary trunk, which then splits into the pulmonary arteries, excuse me. And we then head to the into the pulmonary capillaries. And here they are. And these pulmonary capillaries wrap around the alveoli, all of them, of which there's tons. So there's this really beautiful arrangement here where we've got the oxygen, which is very lipophilic. Respiratory gases, carbon dioxide and oxygen, are lipophilic. So that means they dissolve nicely across cell membranes and easily. So we have this setup where we have this blood supply and this air supply, oxygen supply, essentially right next to one another. The alveoli are single-celled, walled, and the capillaries, of course, we know are single-cell wall. So we're set up perfect for exchange of these very lipophilic substances, oxygen and carbon dioxide. So when we talk about the respiratory membrane, which I think is, in terms of the understanding of the respiratory tract and the anatomy and the physiology and how it all goes together, it's essential to have wrapped in your brain some understanding of the respiratory membrane. And the respiratory membrane is going to be comprised of the alveolar wall and the capillary wall. So we have 2 cell thicknesses plus a basement membrane in between, and we have oxygen on one side in the alveoli, carbon dioxide on the other in the blood, and we have this ability to exchange beautifully based on pressure gradients. So any alteration to this setup is going to potentially inhibit the ability to adequately either expel carbon dioxide or introduce, if you will, to the blood oxygen. So, when you learn about pathology in relationship to the respiratory tract, a lot of it affects this location, this respiratory membrane. All right, so our exchange surfaces are the alveolar sacs. We kind of already talked about the cilia and the mucus, but we'll look at some more pictures. Normal mucus production is about 100 mils a day, which is not very much. As we increase or decrease mucus, in either case, that can have effects. Decrease in mucus decreases our ability to trap particulate. Increase in mucus is more significant in terms of respiratory disease because it can block airways, which we'll get into later. And then there's surfactant. Surfactant is a natural product produced by the cells that line the alveoli. Their alveolar walls are made up of 2 types of cells. We refer to them as pneumocytes because they're found in the lungs. There's type 1 and there's type 2 pneumocytes. Type 1 pneumocytes basically just they're more structural. They make up the wall of the alveoli, walls, I should say, plural. But the type 2 pneumocytes, their job is to produce surfactant. And they're found in the respiratory, they're down there in the alveolar wall as well. So what surfactant is it's essentially like a detergent, and what it does is it decreases surface tension, which means it makes it so the alveoli can inflate without exploding and deflate without collapsing. Surfactant is, like I said, it's produced naturally. In the absence of surfactant, we have disease. So there's 2 scenarios in which surfactant production can be an issue. One is at childbirth, so especially premature babies. So babies that are born prematurely are oftentimes deficient in surfactant. And the reason for that is because the respiratory tract, which makes good sense if you think about it, is the last of the organ systems to develop. There's no point. They don't need their lungs. They're not breathing air in there. So that is the last thing to mature and or develop. And of the part of the respiratory tract that is the very last thing is the type 2 pneumocytes. So they're the last cells on deck, if you will, prior to birth, and they're the ones that produce surfactant. So if the baby is born prematurely, there's a chance that they might not have adequate surfactant, which, as long as that's detected, and it's fairly easy because the baby doesn't, breathe and or scream at the time that they're born, we have exogenous surfactant that we can give. Exosurf or Survanta is an example of surfactant. And just as long as it's caught, as the baby continues to develop and mature, they generally will produce surfactant on their own. So it's sort of a temporary issue. That disease is called infant respiratory distress syndrome, the absence of surfactant. Adults can lose surfactant as well, and that's called adult respiratory distress syndrome. And that is more likely due to some kind of a, maybe like a really bad respiratory infection or the inhalation of some sort of noxious chemical that does damage to the alveoli, specifically to the type 2 pneumocytes, and they're not able to produce as much surfactant. So it tends to be more localized rather than diffuse. In terms of adults, it can be just as detrimental, because what ends up happening is areas of their lungs collapse because of the lack of surfactant. When they expire, the alveoli deflate and collapse, and they can't reinflate because there's too much surface tension to overcome. So surfactant is again produced in the alveoli. There is type 2 pneumocytes, which are not on this picture, but their job is to keep the alveoli from overexpanding and or collapsing. All right, so in terms of conditions that can cause abnormal conditions, that can lead to decreased oxygen tension or decreased oxygen in the blood. These are the pathologies that we're going to sort of be thinking about a little bit later on. One of which is the obstructive disorders. These are the chronic obstructive pulmonary diseases. They are obstructive, so there's some sort of airway blockage for different reasons, which we'll get into. The most common chronic obstructive pulmonary diseases are asthma and emphysema, chronic emphysema or central lobular emphysema / chronic bronchitis. They go together. They're kind of coexist. There's other obstructive pulmonary diseases like cystic fibrosis and things like that, but they're not quite as common. But anytime you have an obstruction, you're not potentially going to be able to get oxygen into the lungs, nor would you, in the case of chronic obstructive pulmonary diseases, are you able to get CO2 out. Sometimes we'll see just a decreased breathing overall, and there's lots of reasons that can cause that. You can have a pneumothorax, which is a collapse of the lung. You can have a depressed respiratory center, and that can be due to all kinds of things. It could be drug related. It could be, there's all kinds of things that could cause that. Pathology, central nervous system, depression, brainstem issues, head trauma, etc. And polio can do it as well. And then we can kind of think about it from the respiratory membrane perspective. So remember that respiratory membrane is comprised of the alveolar wall and the capillary wall. So anytime you have issue with that respiratory membrane, essentially what we're losing is surface area, contact surface area, which means surface area available to exchange your gases. So emphysema can do that because we actually will see alveolar wall degradation over time. Tuberculosis and cancer, they're very different diseases, but they present similarly in the lung, in which they, in both cases, we see a loss of functional surface area, because either with TB, you've got like these granulomas, which are kind of like little tumors. They're not really tumors, but it sort of makes sense to think about them like that because they take up space. And with a lung cancer, you actually do have a true tumor that's taking up space. So that where the tumor is, or the TB granulomas are, they're not able to exchange gases in those cases. And then we've got this issue with diffusion distance, and that refers to the space in between the alveolar wall and the capillary wall. So anytime you get like fluid in there, whether it's because you've got a really bad lung infection like pneumonia, where fluid gets trapped in that space, right, between those two locations, what that does is that causes a increase in the distance that the oxygen and the carbon dioxide has to diffuse, one. But even more to complicate this, when you have fluid in there, that's water, and we know that things are lipid soluble, do not dissolve well in water. So that lipophilic nature of our respiratory gases, oxygen and carbon dioxide, gets kind of thrown out when you put some fluid in there. Heart failure can cause fluid to be trapped in the lungs as well. And that's due, as we've spoken before about in our cardiovascular unit, that's due to the back pressure of the blood into the respiratory tract from the left side of the heart. And it's just pressure, right? It's pressure driven. It's a concentration gradient essentially that pushes the fluid out of the capillaries at the lungs and into that subspace. And then there's things that can cause inconsistent aeration. And again, that would be like an obstruction can do it, some kind of compression, fluid, all of these things. And then there's things that can cause inconsistent circulation. And that would be any kind of block in maybe you've got a clot that's stuck in a pulmonary vessel, so it's not able to get to the respiratory membrane or the alveolar capillary interface. And sometimes we just have circulation abnormalities that are going to cause the issue. So this is a picture of an airway, right? This would be, so this is a bronchiole going into an alveolar duct. And we see a couple things happening here. You see inflammation in the wall of the vessel. And we also see a whole bunch of mucus being stuck in there. So that causes an obstruction. This would be characteristic of emphysema, chronic bronchitis, and also asthma. With asthma, it's episodic, meaning the airway clamps down and then it can relax later. With emphysema or chronic bronchitis, it stays this way all the time. So they have more obstructions in a chronic sense. What happens at the alveoli when you have this kind of a setup? And this is, again, more consistent with emphysema, because asthma waxes and wanes, meaning they have an attack and then the airway constriction, then it relaxes again. But with emphysema, it's chronic because of this chronic irritant, which happens because of things like smoking, or maybe they have a job that is exposing them to a whole bunch of particulate in the air, and they get this chronic inflammation and ultimately destruction of the airways. But when they breathe in, so there's a couple things with chronic with emphysema that are significant and in the transport of these gases. First of all, again, we have this huge concentration gradient for oxygen that exists between the atmosphere and the alveoli. So in most cases, even when there's a lot of inflammation, because the gradient for oxygen, is so large, oxygen will almost always move in here unless this thing is completely collapsed or blocked. But when oxygen moves in, and then carbon dioxide, of course, would come this direction, when we expire, the bronchioles actually do collapse some naturally. And because the gradient for carbon dioxide is not nearly as large, it's like 46 millimeters of mercury in the alveoli and 40 in the atmosphere, the driving force for the expiration of carbon dioxide is not as great. So this tends to, on expiration, collapse because of the obstruction. So this is the obstruction part. There's mucus in here, the airway's inflamed, we get these obstructions. The carbon dioxide gets trapped in the alveoli. And as a consequence of that, the alveoli gets chronically dilated, gets bigger and bigger and bigger, and ultimately can degrade. The walls can degrade. And that's what we see over time with emphysema. Cystic fibrosis is similar. Cystic fibrosis is a genetic disorder that basically centers around aberrant chloride transport, which is not important for us to know here, but it causes a bunch of mucus production in all kinds of areas, not just in the lungs, but the lungs are where we're looking here. So it causes mucus to be produced in mass and stuffed in our airways, and so they get a lot of obstruction and they get a lot of degradation of the alveoli ultimately over time. And they get a lot of bronchiectasis is basically referring to like this thick mucus that's stuck in the airways. All right, I'm sure you guys remember inhalation, exhalation, but just in case you don't, inhalation and expiration or exhalation are all about a kind of a symphony of interactions between coordinated muscle contractions, between the diaphragm, which is our big skeletal muscle of respiration. It's this U-shaped, upside down U-shaped muscle here that runs basically the margin of the ribs. And then we've got the little intercostal muscles, right? The internal and the external intercostals, which basically attach one rib to the rib below to the rib above. So when these muscles contract, the intercostals, it causes the thorax to kind of move up. And as the diaphragm contracts, the diaphragm moves down, so it makes the whole chest cavity larger. And it's a vacuum cavity, so when that happens, when this chamber gets larger, then what it's going to do, the pressure in here is going to drop, and that's going to suck oxygen out of the atmosphere and into the lungs. When we expire, the diaphragm relaxes and just basically pushes the air out of the lungs, and the intercostals relax, and they also facilitate that expiration as well. So that's inhalation, exhalation. The respiratory things to kind of remember that these are skeletal muscles, which means that they are largely under conscious control, even though you don't consciously think about it mostly, but in some respiratory disease that becomes an issue. This is what lungs tissue looks like. The lung tissue is kind of interesting tissue in that it's very diffuse. This is pathology, right? There's these big holes. This is not normal. This is emphysema. Actually, this is what emphysema causes to happen. So basically you're missing all the alveoli in these areas, right? Because they have destruction. Closer up, this is probably due to smoking. This is what a chronic bronchitis / emphysema patient would look like. This could also be someone that's exposed to particulate, like maybe someone that works in a coal mine or something like that. But it's just a lot of, it's this coordinated event where you've got a chronic irritation, inflammation, which leads to alveolar destruction. Asbestos. Asbestos is, of course, a known problem, carcinogen, as well as being a respiratory irritant. Asbestos is like inhaling like microscopic needles. The asbestos fibers are so small that they're undetectable by the mucociliary elevator, so they just float right by. And then they get all the way down into the alveoli, and they sort of lodge in there like little needles, and they cause inflammation and ultimately fluid, and not to mention the fact that they're carcinogenic. So there's a whole bunch of issues with asbestos. This is what lung cancer potentially could look like. So this is a huge tumor, right? That's basically taken over an entire lobe of the lung, which essentially the biggest issue here is everywhere you see tumor, that's an area where you cannot exchange gas. So you're not exchanging any respiratory gases, oxygen and carbon dioxide in this case. This is kind of what tuberculosis looks like. So TB, remember I said it's kind of a little bit like lung cancer. The etiology is different. This is a bacterial infection, but what happens is they get necrosis, they get local tissue death, and it causes these funny things that we call granulomas, which are like just little tumors, right? And they take over the lungs and they don't go anywhere. That's the problem. Once they're there, they stay there and they take up surface area. So that's TB. Okay, so that's our very quick. I went really fast. I'm with the understanding that most of you guys have pretty solid understanding of physiology and anatomy of the respiratory tract. If you don't, you might want to review that a little bit. In the next videos, we're going to be starting to talk about the drugs. So when we come back, we're going to start to look at some respiratory drugs. See you then.